You will see a good amount of admissions on prenatal for this indication, bleeding in pregnancy, whether that be from a Creta spectrum disorder. Let's discuss what those mean. So the first thing that we need to make clear is when a patient comes in to be assessed on assessment, we don't do a vaginal exam until we have ultrasound confirmed findings of where the placenta is. Because if she were to have a placenta previa and we did a vag exam, we run the risk of damaging that placenta with our fingers and causing a massive amount of bleeding. So we always check the prenatal record if she has it before we do a vag exam. If she doesn't have a prenatal record, then she would need a bedside ultrasound to confirm the location of the placenta. We could do a speculum exam, but we would not do a digital vaginal exam with our fingers. So antepartum hemorrhage is defined as any bleeding after 20 weeks, so antepartum meaning during the pregnancy. It does complicate about 2 to 5% of all pregnancies. Number 1 and 2 cause are previa and an abruption, and we'll discuss some other causes of bleeding as well. In a lot of cases, the cause isn't known. So the thing to remember about blood loss in pregnancy, and we're generally speaking about blood that comes out the vagina, is that during the pregnant state, the body is dedicating so much of its cardiac output to oxygenating the uterus, the placenta, the fetus, flushing oxygenated blood through the organ that is the uterus. There's a lot of blood dedicated to this, about 20% in the 3rd trimester. And so when the patient has 7.5 liters of blood on board and she's donating 20% of that through the uterus every minute, she could potentially lose a lot of blood in a short amount of time. And that's why vaginal bleeding in any stage of pregnancy is potentially very dangerous, and it is an urgent situation because a lot of blood can be lost in a short amount of time. So APH is a significant cause of death for the birthing person, but it is a higher incidence of death for the fetus because the fetus has less blood to lose and less compensatory mechanisms in order to deal with the losing of the blood. So let's first discuss placenta previa. So the definition of this is the placenta is touching or covering the cervical os, and os is just a word that means opening. So the cervical opening at a term gestation, so after about 37 weeks. So we do have one in about every 200 to 300 births, so we're going to see this fairly frequently. The other concept would be a low-lying placenta, and that would be the leading edge of the placenta is within 2 centimeters of the internal os at a term gestation. So with a low-lying placenta, you can attempt a vaginal delivery, but your risk of bleeding in the labor is about 30%. The closer the placenta, the higher the risk of bleeding, and some people don't care to take that risk, so then they would opt for the C-section. Just a reminder, there's outdated terms such as marginal previa, marginal placenta, partial previa that are no longer used. So it's either a placenta previa or a low-lying placenta. And so here's just an example of a previa on the left. It is covering the entire cervical opening. The low-lying placenta on the right would be within 2 centimeters. 2 centimeters really isn't a lot measurement wise, so it's very, very close to the cervix. And you see how the baby's head could cause some damage to the placenta as it's passing by. So risk factors for a placenta previa would be having a previous previa, a previous C-section, especially when the interpregnancy interval is less than 12 months, any type of previous surgery on the uterus, including a D&C or a myomectomy, is just an incision in the uterus, so it could have been for a C-section. Advanced maternal age, more than 1 fetus. And then we have multiparities. The more babies you have, the more you are at risk to have a previa. It's just statistical, mathematical certainty. And then finally, in vitro fertilization does have the risk as well. So how do we diagnose a placenta previa? So a transvaginal ultrasound, that's an ultrasound probe inserted up the vagina so it can look straight up at the cervical os and what's covering it. In the second trimester, we'll find it 85% of the time, but the problem in the second trimester is the lower uterine segment hasn't finished growing yet. It's going to do a lot more growing. So the placenta could grow up the wall of the lower uterine segment that's going to develop, and it could get out of the way. And so just because it's a previa in second trimester, that might change by the time you get to the third trimester. So obviously repeat transvaginal ultrasounds would be indicated. And so how does a previa present itself? Typical presentation is bleeding in the second or third trimester, gush of bright red blood, enough to soak a pad. Typically, usually never has pain. So the difference between an abruption and a previa has no pain associated with it because the bleeding doesn't create pressure on the adjacent tissues. It's not irritating anything. It's just bleeding straight from the placenta, not interfering with the uterine wall at all. The first bleed is often at 20 to 22 weeks as the lower uterine segment starts to stretch and grow. The first bleed is very rarely catastrophic. The first bleed is not life-threatening, doesn't result in a lot of blood loss, but the problem with bleeds is the more you have, the worse they tend to get. And so the question is, when's going to be the catastrophic bleed? And that is why we admit patients on prenatal, because we want her to be here in the hospital if she has a catastrophic bleed so that we can intervene right away with delivery of the fetus and removal of the placenta. So we always want to know when her last bleed was and how much blood was there. So if we're questioning at all where the location of the placenta is, we're not going to do a digital exam until the location of the placenta is confirmed by ultrasound. Then if she's having bleeding, the management and decision when we should deliver this patient is going to depend on the hemodynamic stability of fetus and pregnant person. And so the fact is that the birthing person's body has 7.5 liters of blood in it. They could potentially lose a lot of blood before they become unstable. The fetus only has about 350 mils of blood circulating in his body. He doesn't need to lose a very much blood, a very little amount of blood before he becomes unstable. So it's often the fetus that becomes unstable. So you always want your patient to call you so you can have a visual of what kind of bleeding she's had. If it's in the toilet, don't flush the toilet. If it's on a pad, save the pad. We could start weighing the pads to get a quantitative blood loss. Whenever she has a gush of bright red blood, we want to put her on the monitor, see what that baby's doing, and depending on how much bleeding it is, does she have an IV? We maybe want to start resuscitating her with some IV fluids. And if she doesn't have an IV, we're going to want to start an IV during an active bleed. Keeping in mind that we want to keep her group and screen current on her chart. So we're going to redraw group and screen every 96 hours. Sometimes we leave IVs out on these long-term stay patients. We don't routinely restart the IV every 96 hours just for the sake of restarting it. We could get her all the way to term and then we've used up all her good IV sites. So we can leave the IV out if she hasn't bled in a while, but certainly if she starts to bleed again, we're going to want to restart an IV. Make sure that her blood work, CBC, PTT, fibrinogen, make sure it's relatively recent. And then depending on if this patient is preterm, if she's had a gush of blood, if she starts to cramp or bleed, and the fetus is preterm, we're going to want to think about ordering betamethasone to mature that baby. So there's always the chance that a previa patient could need to go to the OR quite urgently or emergently, whether she starts contracting and causes bleeding. or whether she just starts bleeding. And so we always want to make sure we're ready for an emergency C-section. So have an OR chart printed, begin the pre-op checklist. And this includes having the phone number of her support person on the chart. Make sure that NICU has been consulted and anesthesia has been consulted if the physician has ordered it. And then if we are going to the OR fairly urgently, be ready to resuscitate a potentially preterm newborn, but also a hypovolemic newborn. Placental abruption is another major cause of vaginal bleeding in pregnancy. And so what's happening here is, for some reason, sometimes the reason's known, sometimes it's not known, is the placenta is peeling off the uterine wall. It's normally supposed to stay implanted until after the delivery of the baby, but for some reason it is coming off the uterine wall, and that results in bleeding. So the patient may abrupt, and we may or may not see blood out the vagina. It just depends if the blood is accumulating in front of the baby, behind the baby. Just because we don't see blood out the vagina doesn't mean she's not abrupting. So we look at the other clinical signs and symptoms to put the whole picture together and decide, okay, is she abrupting or not? Obviously, the status of the fetus plays a big role in this. The fetus will tell us when he needs to be delivered. So the risks are to mother a patient hemorrhage, hypovolemic shock, but it's even more so a risk to the fetus because he has less blood to deal with. And so sometimes an abruption can cause preterm labor. I mean, if we're sectioning her preterm, that causes preterm birth. So there's risks associated with that. And then anemia and hypoxia to the fetus. Mortality in an abruption can be up to about 35%. So the risk to the fetus is greatest. So what are the risk factors for an abruption? So having had a previous abruption, having a clotting or bleeding disorder, hypertension, PPROM, smoking, cocaine, and twins. So what is the most classic common presentation of an abruption? It generally involves pain. Okay, you're not going to see this all the time, but in general, classic presentation of an abruption is some type of pain, whether it's very sudden and sharp and severe, or whether it's slow onset, dull and aching, generally involves pain. The pain does not come and go like labor contractions do. It usually stays present the whole time. It doesn't let up. And what's going on is the uterus is irritated. So you're going to see possibly irritable uterine activity or abnormal uterine activity. So a lot of activity, it could be firm, might not let up at all, could change shape. You may see squiggles like up and down, up and down, up and down, up and down, that the uterus is very irritated. And then a contraction could present very differently. But generally what's going on and what's causing the pain is that the uterus is irritated. And so you may or may not see blood out the vagina. It may or may not result in maternal hemodynamic stability, just depends on what her pre-status was and how much blood she's lost. And it may or may not result in fetal compromise, because the problem with blood out the vagina is we see the blood, but we don't know whose blood it is. Is it the fetus's or is it the patient's? Because the placenta is the interface between mother and baby. So whose blood is it? We don't often know until after delivery. The clinical picture of the fetus and what he looks like after delivery will generally tell us if he's lost blood or not. And mom's vital signs and blood work, either during the OR or after the OR, will tell us how much blood she's lost as well. And so, like I've said, it can be hard to make this diagnosis when she's still pregnant. We can use ultrasound, we can use maternal vital signs, fetal heart rate tracings, but the diagnosis is often made postpartum when there's a large amount of blood that follows the baby, or you notice the placenta has come off way earlier than you expected it to. So if we suspect an abruption, we can send the placenta to pathology. So care of a placental abruption, any gush of bright red blood, the patient needs to be put on the monitor to keep an eye on what the fetus is doing. You might consider starting an IV and giving her some fluids. You're going to let your charge nurse know. You're going to let your MRP know, because this patient is at risk of needing a C-section very emergently. And then we just keep monitoring what is the blood loss, what is the status of the fetus, what are maternal vitals. She could need an emergency C-section, or what you will find is that patients that are abrupting often do go on to have a precipitous vaginal delivery because the body is irritated, the uterus is irritated. It's trying to get rid of what it thinks it's bothering him. So the uterus. So it will often have a precipitous delivery. And we want to make sure we have baseline set of blood work, or blood work as soon as we can, so we know what her blood work levels are as a baseline. We are now measuring quantitative blood loss, measuring pads, weighing pads, weighing clots, so then we have a better idea of exactly how much blood she has lost. She may have pain, may need pain relief. Abruption pain may or may not break through an epidural. So again, to summarize, your typical presentation of a previa is painless bleeding. It does not have pain associated with the previa. Your abruption typically has pain and an irritable uterus associated with it.